It's pretty cool that we can do this internationally like this. So without further ado, I would like to talk about infection and stroke. And, oops, let me see if I can advance. There we go. Here you can see my disclosure information, of which none of it is really so relevant to the things I'll talk about today, which will focus on infection and stroke. So, when we think about infection and stroke, there are a lot of different ways in which we can think of the relationship. Obviously, one very interesting area right now is the risk of infection after somebody has a stroke. Of course, when people have a stroke, they can develop pneumonia and UTI and bed sores and so forth. And there's been kind of a growing interest in infection occurring after a stroke and its effect on outcomes. And there have been some randomized trials to try to prevent infections after stroke, just empiric treatment with antibiotics. That is not something that I'm going to talk about today, although I do think it's a really interesting topic, and perhaps during the discussion at the end, we can discuss that if people would like to. Instead, what I wanted to focus on today is the work that Timo mentioned I do in epidemiology and looking at inflammation and really infection, particularly as a risk factor for stroke. And so we'll try to answer these three questions. The first one is chronic infection a risk factor for stroke? The second one is acute infection a risk factor for stroke? And if so, what can we do about it? So this slide shows the current thinking about atherosclerosis and proposes that it's really a response to injury. And the idea is that there are a number of different forces that can act on the endothelium and lead either to physical injury or to dysfunction that then sets in motion a whole cascade of immunologically mediated events. So you get monocytes and lymphocytes adhering to the vessel wall. They migrate beneath the surface of the vessel and take up residence there. And then they can accumulate lipids, they become foam cells, macrophages become activated and release cytokines and growth factors, and that leads to then smooth muscle proliferation and growth of the atherosclerotic plaque. And similar inflammatory mechanisms are thought to play a role in plaque rupture and the acute ischemic event. And as you can see, there are a number of different things that may act on the endothelium. Oxidized LDL or hyperlipidemia, probably the best known of these, but there are several others as well, including potentially infectious agents. So some of you may be laboratory scientists and do a lot of work in test tubes and in culture dishes and things like that. I am an epidemiologist and did my training here at Columbia with Ralph Sacco, and so I learned to work in this laboratory here. So this is our laboratory, which is the Northern Manhattan population, basically, and it's the chunk of Manhattan, the island of Manhattan in New York, that's north of George Washington Bridge, which you can see over here on the left. And so all the people sitting in this area up here, which is about 250,000, constitute our laboratory. And the Northern Manhattan study started back in 1993 and has been following almost 4,000 people for the last 20 years now. And in fact, we just got funded to continue follow-up for another 5 years, which is great, and we're very excited about that. But over that time, people had thorough evaluations, including carotid ultrasounds, echocardiography, a subsample of head MRI scans, and laboratory tests. Bloods were collected to run various laboratory tests, and then we could look at the association of these markers to the risk of stroke, heart attack, and other cardiovascular and other events in this population. These were all stroke-free people when they were enrolled, and so it's really a prospective cohort study of the risk of stroke and other events in this population. And so one thing among many that we were able to look at and that I got interested in back when I was in training was the association of inflammatory markers, and in this case, white blood cell count, and the risk of subsequent stroke. So looking at the levels of leukocytes that were measured at baseline in these people before they'd ever had a stroke, we were able to then look at the relationship of white blood cell to subsequent incident ischemic stroke. And as you can see here, those who are in the top quartile of leukocyte count were at increased risk compared to those in the other quartiles. And this is a Kaplan-Meier curve, so it's not really adjusted for other risk factors. But here, after we adjust for age, other demographic features, as well as risk factors, you can see that for those in the top quartile of white blood cell count, there's about a 75% increase in risk of stroke, again, with these white blood cell counts being measured several years before the stroke occurred. So something about having a high white blood cell count leads to an increased risk of stroke. And people have looked at many other inflammatory markers, CRP and so forth, and I don't want to focus on those markers today, but one of the things, again, that could potentially lead to an increase in white blood cell count, of course, is infectious agents. And so that's kind of the line that we'll pursue right now. Now, we're all very familiar, right, with the idea that certain specific infections can lead to stroke. Here's an example of a 39-year-old man who had Staph aureus endocarditis, and you can see he's had two infarcts, different sides of the brain, consistent with a cardioembolic etiology, and he had culture-proven endocarditis. That's not a mystery, and that's not really what we're going to focus on. For many years, we've also known that syphilis can involve the cerebral vessels and cause an arteritis, and that can lead to stroke. And with HIV, we saw some increase in that again. And we still see cases now and then of neurosyphilis. But again, this sort of unusual specific syndrome is not what we're going to focus on. Really, what we're interested in today is more the idea that certain common infections, viruses and potentially bacteria, can contribute to the chronic vessel injury of atherosclerosis or other forms of vessel injury and lead to stroke. And this is really not a new idea. You can see here, there's a paper from 1978 in which these investigators looked at a herpes virus that occurs in chickens. So it's called the Marek's disease herpes virus. And in an experimental model, they were able to induce atherosclerosis in chickens with this virus, even in the absence of high cholesterol levels. Okay, so this is not a new idea. I like this study especially because it was titled A Brief Definitive Report. I thought that indicated a fair amount of confidence. But nonetheless, things kind of fell off the radar screen for a little while there until the 1990s, when people started to notice an association between chlamydia pneumoniae and atherosclerosis. And a lot of this work originally was done in Norway. But chlamydia pneumoniae is a very common respiratory pathogen. It's an obligate intracellular organism, but is capable of infecting all of the major cell types of the vessel wall. So it can infect the endothelia, the monocytes, as well as smooth muscle cells in the arterial wall. And you can find evidence of chlamydia pneumoniae using various techniques like electron microscopy or immunostaining techniques in vascular tissue throughout the body. And it's even been cultured in some cases from coronary and carotid artery specimens. So you can find live organisms. And here's just an example in this slide. This is actually a macrophage, and this is a vesicle within the macrophage containing elementary bodies of chlamydia pneumoniae. And this was taken from an atherosclerotic carotid artery. So you can find chlamydia in the vessel wall, but the question, of course, is whether it's doing anything. Maybe it's just an innocent bystander. It comes into the vessel because of the inflammation of atherosclerosis, and those macrophages bring the chlamydia in, but they're not really doing anything. That's possible. There is some limited, but some animal study evidence that inoculation with chlamydia pneumoniae can cause atherosclerosis, and even that using antibiotics against chlamydia can reduce atherosclerosis. So here's a control animal. Here you can see with chlamydia pneumoniae infection, the increase in intimal thickening and atherosclerosis, and then with treatment that is reduced. So some animal evidence of an association, but whether it plays a role in humans remains unclear. There have been a number of different seroepidemiologic studies done, many done in Europe, but also some done in the United States, including ours in northern Manhattan. And these studies have shown, in general, a suggestion of an association between risk of stroke and serologies against chlamydia pneumoniae. These are all case-control studies, so they are retrospective. They don't eliminate the bias, the possibility that the titers go up after or as a result of stroke. One thing that was interesting, though, in a few of these studies is that IgA titers of chlamydia pneumoniae, which are supposed to represent ongoing chronic infection rather than a remote completed infection, seem to have a stronger association than just IgG antibodies. And we found that in both of our studies. When we went back and validated in a new, fresh cohort, we found the same effect. But again, these are all case-control retrospective studies. And in fact, when others have done meta-analyses of a large number of prospective studies, right, where the serologies are measured before anybody has a cardiovascular event, they have not been as convincing. They showed overall a suggestion, perhaps, of a slight increase in risk. That's a 15% increase in risk, but it failed to meet statistical significance. So if there is an effect, it's likely to be quite small and questionable whether it truly exists or not. Depends on how large the study is and how well you adjust for other risk factors. So I think this kind of data called into question the notion that chlamydia pneumoniae was going to be the stroke bug. There's a lot of enthusiasm, but was it really going to be responsible for all atherosclerosis and stroke? That, I think, is an unlikely approach or an unlikely idea. And so we've moved away from this idea that there's a single stroke bug and instead have started to think about this as an infectious burden, or that all of these different common infections may contribute to an inflammatory burden that can then lead to atherosclerosis and stroke. In other words, just additional contributors to the inflammation that is also produced by cholesterol and homocysteine perhaps, and shear stress from hypertension and so forth. And likely host factors to the infectious agent, perhaps genetic factors or other environmental risk factors like smoking and so forth, may contribute together to this risk of atherosclerosis and stroke. So we looked at this also in the Northern Manhattan study. Among 1,600 participants who had blood samples available for a host of different serologies, we measured antibody titers in our prospective study. So again, before these people had stroke, we measured titers against chlamydia pneumoniae IgA, also H. pylori, which had been implicated in some other studies, and then some common herpes viruses like CMV and HSV1 and 2. And when we looked at each of these individual organism serologies, what we found was that each was associated with risk of stroke with marginal effects, perhaps larger for CMV, but none of them independently were statistically significant. And this was also after adjusting for a number of other risk factors. Now, so then what we did was to create what we called an infectious burden index by taking the parameter estimate or the strength of association of a given infection. And for an individual who had that positive serology, they would get that parameter estimate as part of their infectious burden index, right? So if they were positive for chlamydia pneumoniae, that would contribute to their score. If they were negative for another one, they wouldn't get any points for that. And then we could add up the total of these parameter estimates to arrive at this total infectious burden index in our cohort. And then we looked at this infectious burden index as a risk factor for stroke. And what we found was that in unadjusted models, you can see here, per standard deviation of infectious burden index, there was a 40% increase in risk. Hopefully you can hear me okay. There's, I think, some traffic outside. Is that causing any problems?
It's fine. There's somebody just logged in.
Okay.
I muted him.
Oh, okay, that's fine. I just heard a truck outside. I didn't know if that was disturbing. Okay. And even after adjusting for demographics, risk factors, even for CRP and white blood cell count, you can see that effect, that 40% increase in risk, stays essentially the same. And that was in our full cohort. And then we also did have people with a history of heart disease. When we excluded them, the effects were still present and, in fact, a little bit stronger. So we thought this was consistent with the idea that an overall burden of infectious disease can contribute to risk of first stroke. How that might be is unclear, but we do also, as I mentioned before, we also measure carotid plaque thickness in our cohort at baseline. And so we looked at the association between the same infectious burden index and plaque thickness, and found that those who had a higher infectious burden also had a greater plaque thickness. These are averages, so it's on the order of fractions of millimeter, but we do see in the cohort overall an increase. And again, this is even after adjusting for all of the risk factors that you see down there at the bottom. And then someone near and dear to your heart, Samira Katan, did an analysis when she spent a couple of years with us here looking at the association of this infectious burden index with cognition, and found that the infectious burden was associated with mini-mental status and with our telephone interview for cognitive status at baseline, such that the more infections you had, the lower your cognition. Interestingly, though, it was not associated with a further decline in cognition over time, which may reflect the fact that these were older individuals when they were already enrolled in our study, and so we may have been catching them too late to see the further decline. Recently, though, using a more comprehensive neuropsych battery that we're doing, we have found associations with decline. So the analysis that we did before may have been too rough a measure of cognition. Mira also did a very interesting analysis looking at several different biomarkers and their relationship to risk of stroke. This was done with Leduc funding that she got while she was here. And Mira, of course, has been very interested in copeptin, a measure of the hypothalamic adrenal axis, also looked at pro-ANT, a measure of cardiac stress and function, but also procalcitonin. And procalcitonin is not as popular here in the U.S., I don't think, as it is in Europe. But of course, it's used by many in the critical care field to identify patients with sepsis and to determine how severe the sepsis is and whether antibiotics continue to be indicated and so forth. And again, we don't use it too much here, although it's picking up in use. But we hypothesized, or Mira hypothesized, that procalcitonin as a measure of low-grade infection, bacterial infection, might also be associated with risk of stroke. And in fact, she found that, so that those who were in the top quartile of procalcitonin level had about twice the risk of stroke as those in the lowest quartile. She also found that it was particularly associated with small vessel stroke, which was interesting. And in subsequent analyses, that it is associated with silent strokes and with white matter disease on MRI scans in otherwise healthy individuals. So that paper is under review right now. So interesting there that this may provide another way of looking at this infectious burden concept. So the direction that we're moving in now then is to try to identify some of these host factors and other environmental risk factors that may interact with inflammatory burden. Periodontal disease is another active area of interest here, and we collaborate with our dentists and periodontal pathologists on this. We're not the only one to explore this idea, of course. Some other studies have also found that the number of positive serologies to various infections is associated with risk of cardiovascular mortality and with carotid disease. And periodontal disease, again, I apologize for showing this to you. You're all about to go home and have dinner soon, so I hope this doesn't turn you off too much. But periodontal disease is really like having a terrible festering sore in your mouth. And so it's known that it's associated with elevated levels of CRP and other inflammatory markers and may also contribute to vascular disease. And it's interesting, you know, one wonders why if bacteria and infections are so important to atherosclerosis and stroke, then why don't we find them more often in atheromatous tissue? And what about Koch's postulates that says, you know, you should be able to treat the agent and it goes away and the atherosclerosis gets better and so forth. But Koch's postulates don't really apply in this case where you have chronic low-grade infection. And in one analysis that was done here by one of our dental pathologists, we collected plaque specimens from the carotid and other vessels at surgery, and they found that they could recover bacteria from those specimens at a much higher rate when they incubated the specimens, the plaque tissue from the arteries, with monocytes. And that's because several of these organisms are really, they are helped by monocytes, and sometimes they only survive within the monocytes themselves. And so by doing that, they were able to identify a number of different pathogens in carotid and other plaque specimens, some of which are common in periodontal disease. So, and it wasn't, again, just a single agent, but several different infections that seem to be involved. And so that also seems to go along with this idea of an infectious burden being the operative way in which infections may contribute chronically to stroke risk. So just to go back then and try to answer that first question, is chronic infection a risk factor for stroke? Obviously, some specific infections like syphilis and endocarditis are associated with stroke syndromes, and it's unlikely that one infection alone is going to account for a majority of stroke. But the burden of common infections may be associated with long-term stroke risk, just like another risk factor, and may also be associated with other markers of cardiovascular disease like carotid disease, like cognition and dementia potentially. You know, we need to figure out what the effect modifiers are, and then, of course, see if there's anything we can do to affect the risk and reverse disease. So let me switch directions right now and move from the question of chronic infection to talk about acute infection. So in this case, what I want to do is try to shift your thinking a little bit. You know, we know what most of the stroke risk factors are, right? High blood pressure, diabetes, cholesterol, smoking, et cetera, et cetera. We know that people who have those risk factors are more likely to have strokes than people without those risk factors. That's what the last 50 years or whatever of epidemiology have taught us. But it doesn't tell us why a given individual who has those risk factors has a stroke on a particular day and time. You know, the diabetic smoker, why did they have their stroke today rather than a week ago or 2 months from now or 2 years from now? And so the question then shifts from why me, you know, why this individual, to why now? Why does a stroke happen at a certain point in time, and what can we do to prevent it? Is it some kind of random stochastic event, or is it somehow predictable, and can we identify people at high short-term risk who we can then treat to prevent the stroke from occurring? So to get at this question, I worked with the Cardiovascular Health Study, which is another large epidemiologic study in the U.S., and they had a data set that lent itself to trying to address this question. And CHS is a cohort of almost 6,000 people over the age of 65 in the U.S. They're drawn from 4 different centers around the country. They were enrolled back in the early 90s. We looked at stroke, and we did what's called a case crossover design to try to get at this question, not of who has the stroke, but why do people have a stroke at a particular point in time? And specifically, we looked at the relationship between a hospitalization for an infection and the risk of having a stroke. So in this kind of analysis, what you look at, rather than doing a case control across people, you're doing a case period of time versus control periods of time, and looking for the relationship of hospitalization for an infection in one period of time and a stroke in another period of time. So let me just show you how it works. So imagine somebody who's recruited in 1990 in this cohort and followed over time. You know, they've never had a stroke. They're followed up over time, and boom, they have a stroke December 30th, 2004. Then we look at the 90-day time window, period of time, prior to their having a stroke, and we look to see whether they had any hospitalizations for infection during that time window. And then we look at the same calendar time, 1 year before and 2 years before, and look at the occurrence of hospitalization for infection in these time windows versus in the case time window. So it's a within-person type of analysis. So there were in the cohort 11% of people who had strokes, 669 of them. You can see their characteristics here. And among that group of people who had strokes, you can see the infections that occurred here. And you can see there were a total of 36 infections during the case period, the 90 days prior to the stroke, and in 2 90-day control periods, right? So it's 180 days, twice as long. There were only 21 infections. Most of the infections were respiratory, UTIs as well, and then a smattering of other infections as well. So again, this was not specific for a particular kind of infection. Now, those are just the crude numbers. When we did a logistic analysis, we found that for those who had a hospitalization during those control intervals, there was a threefold increase in risk of stroke in those 90 days. And then the advantage to this kind of analysis is that you can change the time window that you're looking at. And so we could look at 30 days and even 14 days prior to the stroke. And the shorter the time window, the higher the risk of stroke after that hospitalization for infection, suggesting that, you know, there's the closer you are in time to the recent hospitalization for infection, the higher your risk of having a stroke. Now, this type of analysis does have some limitations. We're looking at time intervals 1 and 2 years before. People do get older. Your risk of stroke goes up with age, so that's one issue. We can't eliminate all forms of bias. And so we did a confirmatory analysis, a more typical Cox proportional hazard model, in which we basically just looked at people over time. We followed them over time, and whenever somebody was hospitalized for an infection, we considered them as being exposed, and we could make that time of exposure 14, 30, 90 days, whatever we want. And then after that period of exposure, they would go back to unexposed. And so people could have more than one period of exposure time. And so we were then able to do what's called the time dependence analysis and see whether the risk goes up during those time intervals. So this is now in the full cohort of 5,600 and some odd people. And when we did the analysis, we found, again, within a 90-day window of their hospitalization for infection, there was a threefold increase in risk of stroke before adjusting for other risk factors. When we adjust for other risk factors, including diabetes and smoking, as well as carotid plaque thickness as kind of a general measure of atherosclerosis, there was a decrement in that increase in risk, but it was still statistically significant. When we looked at 30 days and 14 days, again, the risks seemed to increase, not unlike what we saw with the case crossover analysis. And also, you can see that the magnitude of association is stronger here as you get closer in time, and there's very little attenuation of the effect for adjusting for other risk factors. And so it looks like being hospitalized with an infection will increase your risk for stroke. The mechanism of this is not clear from our study. There are other studies and models that suggest how this might occur. We know that infections can lead to activation of leukocytes, also of platelets, of the coagulation system. It can lead to increased interaction between leukocytes and platelets, making them stickier, and this might then provoke a thrombotic event. And there are probably many other mechanisms as well, and I won't get into mechanisms right now. And there are several limitations, of course, to the kind of analysis I showed you. We used administrative data, ICD-9 codes, to define these infections, and this was limited to the hospitalized infections. As I said, the mechanism is really uncertain. It could just be that when you're hospitalized for anything, there's an increase in risk. We did actually look at surgical hospitalizations as well, and we didn't find the same association there. So that suggests it may be specific to infection, but hard to say for sure. There could be lots of other things going on when people get hospitalized with an infection. For example, they might stop taking a medication that might be protective, like a antiplatelet agent and so forth. So that could be a mechanism. And I mentioned the problems with these time-related covariates, such as aging, as well as development of new risk factors and changes in medications. And this, of course, may not be generalizable to others also. But it does suggest potentially some association and some vulnerable period after an acute infection. Again, others have also looked into this question. So this is data from Liam Smith from the UK Practitioners Database, in which they looked at the relationship of outpatient infections as well and subsequent stroke using the medical record linkage system that they have in the UK. And so they found that respiratory tract infections were associated with an increased risk of stroke. And again, you can see this effect so that the closer you are to the infection, the higher the risk. And it remained increased out to 90 days when they looked, but with a much smaller effect size. And there's similarly an association for urinary tract infections, though not quite as high. And interestingly, in their data, there was also a decrease in risk with vaccination against flu. And so this has been seen also that if you can prevent the flu with vaccine, you may prevent stroke and cardiovascular events. Although I would say, there's never really been a good randomized trial proving that, but there's a lot of suggestive data. We also did look in another cohort in the U.S. This is work that was done by one of our graduate students, Jorge Luna, who looked at the California inpatient data set, basically using the same case crossover design. He looked at those who had strokes in the year 2009, and then looked at 1 year prior, using these 90-day time windows, and 1 year prior to that, and looked for episodes of what are influenza-like illness, so what our CDC uses to identify people with the flu, and found a higher prevalence of influenza-like illness in the 90 days prior to people having their stroke than in the 2 years prior. Now, one advantage to looking at the California data set that we have here, this is basically every hospitalization in the state of California. So it's millions and millions of hospitalizations and a total of 41,000 strokes. So the numbers are very large. And this is just the definition of influenza-like illness. It uses all of these different ICD-9 codes here to create this algorithm for the definition. So when Jorge did his case crossover analysis, he also found that the shorter the time window, the stronger the association with risk of stroke. This is also adjusted for season because that can impact the occurrence of flu, of course. But because it was such a large cohort, he was also able to look at different age strata. And even among people who are less than 45 years old, which is obviously a very young age to have a stroke, and so a rare event, there was a pretty dramatic increase in the risk of stroke, associated with flu-like illness in this 30-day window. Very large confidence intervals, but a much bigger effect there. So it may tell us something about the risk of infection and stroke in the young. And in fact, there is growing evidence that infection may play a role in stroke in children. Now, stroke in children, fortunately, is very uncommon, so it's a hard thing to study, but a number of very good child neurologists like Heather Fullerton at UCSF and Gabrielle de Weber at Toronto, sick kids, have been studying this question for several years, and we here at Columbia had the opportunity to collaborate with them on their project recently. This is just some preliminary data from several smaller studies showing that preceding infection is associated with a high increase in risk of stroke among children in several different studies. And these were mostly viral syndromes. And Silke, are you requesting access to my computer?
No.
No? Okay, I just got a message.
No.
Okay, sorry. I just got a message on my screen. Let's see. Okay, and so chickenpox, for example, is known to be one of these specific infections that can lead to an arteriopathy and stroke in children. And you can see an example of that here, but the question is whether infections more generally might contribute to stroke risk in children. And so Heather and Gabrielle got this study up and going called the Vascular Effects of Infection in Pediatric Stroke Study, or VIPS, and basically enrolled about 350 kids at 40 centers around the world. To study stroke in children, you have to enroll, you have to include a number of centers because each center only has a very small number annually. So they were able to get 40 centers, including Australia, Hong Kong, Croatia. I don't know if there were any in Switzerland involved. And each center enrolled kids with stroke as well as controls. It's hard to draw blood from children who are otherwise well, so we used children who had had a recent traumatic event, were in the ER because they broke a limb from, playing on the swing set, something like that, and so they were having blood drawn as part of their routine evaluation. So those were the controls. And so you can see here there were 355 kids with stroke, median age of 8, mostly boys, and about the same number of kids without stroke. These were the controls. We actually we didn't have blood samples on all of the controls, but in those who we did, which was 120, we were able to we looked at a history of infection based on parental report, and there was an association with a history of parental report, and actually that paper is in press now. But in addition, here at Columbia, we were able to look at serologies against a number of different herpes infections. The hypothesis was that if varicella might be associated with vasculopathy and stroke, then perhaps other herpes infections would as well. And so what we found was that there was a higher prevalence of acute herpes infection in those kids who had a recent stroke than in the control sample. And you can see that there were a number of different herpes viruses implicated, again, consistent with that idea of a inflammatory or infectious burden. Interestingly, about half of those who had evidence of infection serologically did report a history of infection recently as well. And so that means that, a lot of them probably did have an infection, but also might mean that some of these infections could be subclinical and yet still be associated with subsequent vascular injury and stroke risk. In addition, we were able to take our stored specimens from these kids and do kind of a high throughput approach, looking for many different organisms, working with Ian Lipkin here, who's a virologist and kind of a microbe hunter at Columbia. Using mass tag PCR, you can look for a whole host of different bacterial and viral pathogens. And interestingly, we found about 10% had evidence of some other infection, and 10 of the 16 who had evidence of another infection had parvovirus B19 DNA in their blood. And that's compared with 0% of the control population and 0% in healthy children based on published studies. So some proportion of these kids seem to have evidence of recent parvovirus B19 infection. And parvovirus B19 has been the virus that causes the what we call fist disease, or the slap cheek syndrome, these red cheeks that kids can get from it. This is a particularly nasty example. But the virus can infect red blood cells and potentially also other endothelial cells, and particularly in patients with sickle cell disease, it can lead to a crisis, but it may also be associated with stroke. And there are some case reports of this as well, and so perhaps it's a more widespread phenomenon and may account for more strokes in children than we're aware of. So, but it was a nice example of how using a high-throughput screen we could identify additional infectious organisms that might be associated with stroke risk. We also found that vaccinations, routine vaccinations that children should be getting, reduce their risk of having a stroke, consistent with this infectious idea. So is acute infection a risk factor for stroke? I would say that acute infections are likely associated with a near-term stroke risk. In other words, they act as a stroke trigger, and that could include flu, pneumonia, UTI, as well as herpes viruses, and vaccinations are probably going to be protective. So let me finally then just move on to my last point, which is, okay, if infections do relate to stroke, what can we do about it? And I'll just make a couple of comments on this, and maybe people will have additional thoughts about it. But I would say that we could think of it as kind of moving into a different paradigm about prevention. Initially, we often thought about the vulnerable plaque, and then we began to recognize that individuals probably had multiple plaques in different areas at the same time, even if one was the only symptomatic one. And this led to the idea of the vulnerable patient, or the idea that the systemic milieu inside an individual may contribute to their risk. And that's why we're interested in things like C-reactive protein as a measure of systemic inflammation that may put somebody at risk. And I would add that the next step could be to look at the vulnerable time period, say the time period after somebody has hospitalization for infection, an episode of the flu, a UTI, etc., might be an especially high-risk period during which we could potentially intervene and prevent somebody from going on to have an event. So things that we could do that all need to be proven would be vaccinations. Now, it's interesting that flu vaccine is the first one that's been recommended by the AHA, American Heart Association, and the American College of Cardiology as a vascular preventive strategy. So, according to U.S. guidelines now, people with heart disease or cardiovascular disease should get flu vaccine, not just to prevent the flu, but to prevent the cardiovascular complications that can follow that. So again, no clinical trial has proven that very well, but that's in our current guidelines. So that's the first anti-infective strategy to make its way into treatment recommendations. Secondly, potentially we could identify people who are at increased long-term risk due to measures like infectious burden, maybe MIRA, procalcitonin, or related markers, and then put them on drug therapy. It might be antibiotics for the infections, it might be anti-inflammatories for this notion of chronic inflammation, or it could be statins and blood sugar control and conventional approaches to reducing risk. So you're recognizing people as being at high risk by virtue of infection, but the treatment may actually be conventional preventive strategies. Currently, actually, in the U.S., there is a trial going on using methotrexate to prevent heart attack in patients with cardiovascular disease as an anti-inflammatory strategy. And then thirdly, we could identify people who are at increased short-term risk due to having a recent urinary or respiratory or other infection, and do similar things with them, put them on aspirin, statins, etc., to prevent their going on to have a vascular event. So these things, I would suggest, are potential avenues for future clinical trials rather than proven things right now. So let me just finally conclude then by saying some common infections may contribute to the inflammatory burden that leads to atherosclerosis, other forms of vascular disease, and stroke. I do think that acute infection is going to be a trigger for stroke, and I'm kind of excited to see what happens with that in the future. Flu vaccine should probably be recommended to all patients with stroke and at risk for stroke. Every patient who comes into the U.S. hospitals now gets flu vaccine, so it's unlikely we're going to be able to study that, at least in recurrent stroke, very well. And then primary preventive strategies could focus on those at high risk, including those potentially with recent infections. I'd like to finish just by acknowledging my collaborators, particularly in the Northern Manhattan study. Ralph Sacco, who's now the chairman at the University of Miami, continues to be a close collaborator, and NOMAS, as I said, is refunded now and continues to be a collaboration between Columbia and the University of Miami, as well as Mount Sinai, where one of our former fellows, Mandeep Damoon, is now a professor. And who knows, maybe we'll have a U.S. And Swiss site as well with Mira and Timo, and perhaps some of you as well. We would welcome any further collaboration. And then some of the other work, just want to acknowledge the cardiovascular health study, the VIPS project. I didn't really show you data from the LIMITS project. And of course, acknowledge the NIH for its funding of these projects. I will stop there. Thank you very much for your attention, and I'd be happy to take any questions at this point. I can hear you applauding now. I wasn't sure anybody was really there, but now I know.
Mitch, thank you very much for this really outstanding presentation on this interesting topic. And we are open for questions now. Maybe any questions from Lausanne? Tschüss, Patrick. Or from Zurich, Mira?
Hi, can you hear me?
I can hear you, Mira. How are you?
How are you?
Good, how are you?
Nice to hear you. Wonderful presentation.
Thank you, Mira.
I have some small questions regarding the vulnerable time period. Did you also look at severity of infection or any within those patients who were hospitalized due to infection in this time frame? Was there a subpopulation which was probably even at a higher risk? So was infectious severity an issue, or did you find anything, something like that?
Yeah, that's a really good question. We certainly didn't do that in this analysis. You know, we had, again, administrative data that told us people were hospitalized for an infection. We had lots of different infections, although not so many that we could divide it up into different subgroups. So we didn't look at that. But if one had the individual, data about their, the course of their hospitalization and how sick they were, I suppose you could. And I think one interesting area that actually, I don't know if you met Mira, Amelia Boehm, who is one of our postdocs currently and is joining faculty here, has been looking at systemic inflammatory response syndrome and risk of stroke. That's more occurring after the stroke, and finding that if you have a stroke and you have SIRS, you're likely to have a worse outcome. So I think that's a really good idea to look at that, and we'll have to think about where we might capture that information. I do know there have been studies looking at sepsis, and we did this with the California data as well. Sepsis is associated with subsequent risk of stroke, and so it probably is related to severity. That would make sense.
And one other comment is that you have said that it's age dependent, so that the younger even have a higher, or at least seem to have a higher risk. Might it be that infection, because there is data on infection and dissection is one of the reasons, or of the more common reasons for stroke in young people. So there would be also probably an interesting link.
Yeah, that's a great idea also, and we didn't break it out by cause of stroke in that analysis, but given the fact that there are 40,000 strokes, we probably could look at dissections as a subgroup. So thanks for that idea. We'll do that. As always, great ideas, Mira. Thank you.
All right, thank you, Mira. So, any questions from St. Gallen or Lucerne, Geneva?
Everybody's hungry for dinner there.
Yeah, you're right. Just a second, Mitch. So, Lucerne, Geneva, and Rheinfelden. Okay. I think it was really a clear talk, so Mitch. Aarau?
Thank you very much, Mitch, for this excellent, comprehensive overview on stroke and infection. Some 13 years ago, I spent 2 years at the Department of Neuroradiology in Bern, in Switzerland, and at that time point, we systematically assess the dental status of patients undergoing CT for stroke, and we found an increased prevalence of radiological hints, markers of periodontal disease in patients with stroke, much higher than it is reported in the general population. But we always felt that the association between periodontal disease and stroke is due to the association between bad dental status and some unhealthy habits like heavy drinking or cigarette smoking. Do you think that periodontal disease is an independent risk factor for stroke, or what is your opinion on this?
Yeah, it's a really good question, and there are so many potential confounders. We see this with CRP, of course. So, CRP goes up with things that are bad for you, like smoking and diabetes and obesity, and goes down with healthy behaviors. And so, it's very hard to show an independent effect of CRP. And I think the same holds true for periodontal disease. There are definitely studies, and many studies, that have shown an independent effect in epidemiologic studies. But there's still that question of residual confounding. How well are we measuring the other risk factors? We divide people into hypertensive or not, but of course people exist on a spectrum, and so are we really capturing the risk of their blood pressure adequately, their blood sugar, all these other things? So the only way to answer the question definitively is to do something like a trial and treat people's periodontal disease and see if you can reduce their risk. And that hasn't really happened yet. There have been some trials looking at periodontal disease and preterm loss of fetus in women. There was a paper in the New England Journal a few years ago. They also couldn't prove a benefit. There have been some studies looking at carotid plaque similarly with periodontal treatment that have been kind of equivocal. So I think you're right. It's a hard thing to prove. We need to do a better job of looking at that. Yeah, that's true.
All right, thank you. And just one question. Do you check for some infections, for example, for syphilis, on a regular basis or in a certain subpopulation in the clinical routine?
Yeah, that's a good question. We don't test everybody for syphilis. But if there's anything that is not immediately apparent as the cause of their stroke, then we will. So we have a low threshold for testing for it. Now that you say it, I think in the U.S. guidelines for, acute treatment of stroke or evaluation of stroke, they do discuss checking an RPR in virtually everybody. I'd have to double check that, but So we have a low threshold for checking, but not everybody. And other infections, we don't, like chlamydia and things like that, we don't routinely check, again, because I think it's more of this chronic inflammatory burden than any particular infection.